35-year-old male who come with back pain. And on the BT, we have destructive lytic lesion on L2 vertebral area. Serum creatinine and calcium is in the normal range. Blood count test is also normal. Bone marrow shows 5% plasma cells, which is normal. When we have more than 10% or 10% plasma cells, we diagnose multiple myeloma, right? So serum immunization electrophoresis shows no M-band present, which means no light chains present, which causes M-band, increased M-band. When we have M-band, which is associated with IgM, we diagnose Waldenström macroglobulinemia. When it's IgG associated, we diagnose multiple myeloma, right? So light chain disease, choice A, is wrong because serum electrophoresis is normal, which means we don't have any light chains, right? Benign monoclonal gammopathy. Benign monoclonal gammopathy, again, is associated with the increased light chains, which causes increased erythrocyte sedimentation rate, ESR, and it's not will be as significantly increased as it will be in multiple myeloma. And benign monoclonal gammopathy is a look like multiple myeloma, but present more benign, right? And patient usually comes with only increased ESR, and when you check his or her bone marrow, you can see like 6-7 plasma cell, which is abnormal, but not 10%, which is diagnostic for multiple myeloma, right? Then smoldering myeloma. Smoldering myeloma is also associated with increased light chains, right? So serum electrophoresis will be, again, abnormal. And smoldering myeloma is associated with inside multiple myeloma signs, which means increased light chains, increased plasma cells in the bone marrow biopsy, but it does not present with any external presentation, any external signs. I mean, with there's no lytic lesions, which means no hypercalcemia, which means no renal insufficiency, because renal insufficiency is associated with hypercalcemia on multiple myeloma, whereas renal damage is associated with light chains. And when we talk about nephropathy, right, is associated with amyloidosis in multiple myeloma. Next is solitary plasmacytoma, which is by its OMA telling us that it's mass, right? Solitary plasmacytoma, it is our diagnosis here, because the only abnormal thing we have in this case is that he has lytic lesion, lytic mass on his L2 vertebral area, right? So our diagnosis here is solitary plasmacytoma. And solitary plasmacytoma is not associated with anything else, just only mass, lytic mass on his, usually, like most of the time, on his vertebral area or her, right? And there will be normal electrophoresis, normal plasma cells in his bone marrow biopsy, and therefore this is answer D is our diagnosis here. So multiple myeloma is classically, right, associated with more than 10% of plasma cells in bone marrow biopsy. It's associated with increased light chains, right, which will cause M-band present on serum electrophoresis, and it's this M band is associated with EEG. It is so important for you, Smally. Asked multiple times that EEG is for multiple myeloma, EGM is for Waldenström macroglobulinemia, and also in Waldenström macroglobulinemia, you usually can see that there is splenomegaly or a lymphadenopathy, whereas in multiple myeloma, you will never ever see that